dear doctors, I, Suresh Tiwari, welcome you all to this novel initiative by Mumbai Hematology Group and Professor Dr. M.B. Agarwal sir. Today's webinar is on an interesting topic named Platelet Puzzle, why precision is important in testing matters. So at INTAS, we are thankful to Professor Dr. M.B. Agarwal sir, who is a program director, also an innovation. So we are fortunate to have him because he has enriched us by collaborating with various stalwarts in hematology across the globe, and he has been awarded Inspiring Hematologist of India, including very recently the Guru Dronacharya Award. So, sir, over to you, sir, and we request you for the further proceedings, sir.
Yeah, over to Dr. Varun Bafna.
Can I share Kalpesh now?
Yes, sir.
Yeah. Good morning to one and all. A warm welcome. Myself, Dr. Varun Bafna. I'm a hematologist in Kolhapur, Maharashtra. On behalf of Mumbai Hematology Group, I'm warm welcome all the delegates. Today's guest speaker, Dr. Vidisha Mahajan from Mumbai. She will be delivering lecture on the platelet puzzle, why precision in testing matters, under the aegis of Mumbai Hematology Group, with the help of our sponsors, INTAS, and the coordinating team Perfect Square. We thank you, Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Shilpa Gupta, Mumbai, our chief speaker, Dr. Vidisha Mahajan, Mumbai, on all our discussants who are themselves eminent hematologists, hemato-oncologists from the different part of the country. You participants for sparing your Sunday morning. It's a warm welcome for all. For this week, coming webinar is ABC of Molecular Hematology for the Beginners in the Clinical Hematology. Will be on the Saturday, 23rd of March at 7 p.m. by Dr. Amrit Kaur Kaler from Kokila Ben Hospital, Mumbai. And on Sunday, the 1 week later down, Atezolizumab-based treatment of CML. She'll be at same time from Dr. Delphine Ria from Paris, France. So today's discussants are various hematologists, eminent hematologists and oncologists from the different part of the country. Dr. Gunjan Lone, she's Vokad Hospital, Nagpur. Dr. Ketan Modak from NCI, Nagpur. Dr. Kunal Chatani, BL Kapoor Hospital, Delhi, now working in Nagpur. Colonel Dr. Kundan Mishra from Army Hospital, Delhi. Dr. Manoj Toshniwal from Aurangabad. Dr. Neha Ganju from Ganju Hematology Clinic and Hospital, Nagpur. Dr. Nikhil Kumar from AIMS, Delhi. Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur. Dr. Pankaj Tantia from Bikaner. Dr. Richa Guneja from AIMS, Nagpur. Dr. Upendra Sharma, Bhagwan Mahavir Cancer Hospital, Jaipur. Myself, Dr. Varun Bafna from Dr. Bafna Star Super Speciality Clinic and Hospital, Kolhapur. Dr. Vinod Gunasekaran from Trichy, Tamil Nadu. And Dr. Vishwadeep Khushbu, AIMS, Nagpur. So I welcome our guest speaker. Today is Dr. Vidisha Mahajan, Mumbai. She is a consultant hematopathologist from the Department of Laboratory Medicine, PD Hinduja Hospital and Medicine Research Center, Mahim, Mumbai. After completing her MBBS and MD Pathology from Indira Gandhi Medical College, Shimla, she joined Tata Memorial Center for training in hematopathology. She advanced her experience in flow cytometry at Segal Path Laboratory, a center of excellence, with a keen interest in diagnosis and response assessment of hematological malignancies. She has spent a brief period at Hematologics at Seattle, a global hub for flow cytometry. Her routinely publications in various national and international journals on hematopathology She was involved in postgraduate teaching and accreditation activities during her tenure at IGMC, Shimla, and BARC Hospital, Mumbai. So she will be delivering a lecture on platelet puzzle, why precision in testing matters. Our today's special guest, Dr. Shilpa Gupta from Mumbai. She is a consultant hemato-oncologist at B Positive Heme Clinic attached to Holy Spirit Bhakti Vedanta Hospital and Vokad Hospital. She is trained at esteemed institutes like St. GS Medical College, Grand Medical College, Bombay Hospital, and Tata Memorial Hospital under the guidance of best of the teachers like Dr. N.B. Agarwal and Dr. Reena Nair with around 17 years of experience. Her international publications in the Journal of Leukemia and Lymphoma on APML that received attention of stalwarts in the field Loke Martin Tolman. She had a book chapter on gastrointestinal lymphomas. She has been a principal investigator and co-investigator in various trials like peripheral T-cell lymphoma, chronic ITP, etc. So today's lecture and program will be inaugurated with her words of wisdom. I welcome Dr. Shilpa and I'll share the session with you.
Thank you so much, Dr. Varun, for this kind introduction. Words of wisdom. I would like to start with a Sanskrit shloka, by which we usually inaugurate our any spiritual sessions. It goes like this: Om Agyanati Mirandasya Gyananjana Shalakaya Chakshurun Militam Yena Tasmai Shri Guruve Namah. Literally translates into it's actually meant for the spiritual master who gives you, takes you from darkness of ignorance to knowledge. So here we are gathered here to gain the knowledge in hematology, and I really respectfully from the deepest of my heart pay my obeisances to my teachers, especially Dr. M.B. Agarwal and all my teachers whom I have been really I have been very fortunate in my career to have had the best of teachers, right? From my days in KEM Hospital to my MD under Dr. Joglikar sir, Dr. Alka Deshpande. Then I met Dr. M.B. Agarwal. Then I went on to learn at Tata. And under the guidance of Dr. Reena Nair, Dr. Hari Menon, Dr. Manju Singer, Dr. Naveen Khatri, I have been really blessed to be having been taught from the best of teachers. So teacher can actually change your life. But when we, during our learning also, as well as when we are in our practice, the best teacher that we come across is our patients. We can never undermine, and we should be always thankful to our patients because they are not only they give their lives and the decisions making of their decision making in their the diseases to us, and having that faith in us that we can take decisions for them and help them in overcoming this disease is something which we should be thankful, not they alone. We should be thankful to them that they trust us that much. If we go with that attitude, and if we take time for the students who are listening, what is happening these days, which I see amongst in my hospitals, amongst the students, is that we are becoming more investigation based. So we have our history taking an examination has definitely taken a backseat. So I request all the students to go ahead and talk to the patient. Patient tells the diagnosis yourself. This is what we have learned in our MBBS days. If we take a proper history, do a good clinical examination, and then order certain investigations just to confirm what is our clinical diagnosis. This is the right way, according to me. It may sound old school, but this is the right way to go about making a diagnosis for the patient. So in this world where we are dealing with the AI taking up jobs, there is a possibility that medicine and subsequently hematology, oncology may be one field which may not be taken away by the storm of AI because of this compassionate attitude which we can have towards our patients. So this is what I have learned from my teachers, and I really thank Dr. M.B. Agarwal, Dr. Varun, Dr. MHG to actually allow me to say a few words over here. I'm not sure whether I deserve this, but I did it because Sir told me to. Thank you so much. I hand over the session to Dr. Varun, and I really look forward to hearing from Dr. Vidisha. Thanks a lot.
Yeah, thank you, ma'am, for such a kind and wonderful words. I think in this era, the need of the hour, what you have told, we should always never forget our teachers and what they have told. By this, I would like to hand over the session to Dr. Vidisha, but everybody is waiting to hear you. And next, you can take over, ma'am.
I hope I'm audible.
You are audible.
Okay. So in the beginning, I would like to thank Dr. Varun Bafna for the kind introduction, and Dr. and MB Agarwal sir and MHG for giving me this opportunity. And as Dr. Shilpa Gupta rightly said, the patient and the clinico-pathological correlation is the best way to treat the patients. And this is what I would be going through in my presentation, where we discuss some real-life cases. So I would like to begin my presentation. So as we begin this topic, today we are speaking about a topic which seems like a puzzle, but has real life consequences, because a platelet count is reported with every complete blood count given to the patient. And it has, the precision is not a technical detail itself, but is a crucial factor in ensuring healthcare in a patient, because these counts decide whether the patient should be is at risk of bleeding, should be requires transfusion or not. So coming initially to the physiology of the platelets. So whenever there is a breach in the blood vessel, there is a vascular spasm leading to vasoconstriction. There's exposure to the subendothelial collagen, which leads to platelet rolling and addition. A single platelet will come, it will lead to the release of certain chemokines, mediators, which attract other platelets, and they all come together like small pieces of puzzles to form a nice primary platelet plug, which is the primary hemostatic plug. These platelets further release secondary mediators to lead to the coagulation cascade. So whenever we are working up any patient for a basic coagulation testing, we take the international, the BAT score or the bleeding assessment tool, which is used to know about the bleeding pattern in the patient. What is the duration of the bleeding? What is the pattern of the bleeding? What is the severity of the bleeding? And this, we take a history of the patient, whether the patient has any epistaxis, cutaneous bleeds, GI bleed, hematuria, menorrhagia, or PPH, or any kind of CNS bleeding, and what is the duration of this bleeding. After that, we do a complete blood count in the patient, which includes the hemoglobin, the WBC count, and the platelets. Then the test for primary hemostasis include the bleeding time. We used to also do the clotting time, which is no longer done because it's redundant. Then the closure time or the platelet function assay is done by using a PFA 100 machine. And we generally, I will be talking about this in detail later on. Then a test for secondary hemostasis basically leads to testing for the coagulation factors. So prothrombin time measures factor 7, activated partial thromboplastin time measures factor 8, 9, 11, and 12, which are the factors involved in the intrinsic pathway. And the thrombin time is used for testing in many abnormalities in the fibrinogen levels. Coming to the platelet counts. So platelet counts have been done in the CBC analyzers right from the beginning. Initially, the International Society for Hematology considered manual counts done on the Newbar's chambers as the gold standard. Then came the automated cell counters using various methods like impedance, optical method, or the fluorescence method to give us an accurate platelet count. All these automated cell counters have to be compared, and the comparison has to be done on microscopy to see if we are giving the accurate counts. And the gold standard now given by the ICHS is the flow cytometry, where the RBC to the platelet ratio is done. So the manual platelet count was the gold standard for counting platelets from 1988 to 2001, in which a hemocytometer was used to do a manual platelet count. The central chamber was counted, in which the purple squares which we see in the periphery, the platelet count was within normal range, only these small squares were counted. If the platelet count was less than 50,000, then the entire cell needed to be counted. And we used ammonium oxalate to lyse the RBCs. But this was a very laborious, a very subjective method of counting platelets, which has a documented inter-observer variability of 10 to 25%, which is very big if you are doing a low platelet count, especially if the decision to transfuse the patient has to be taken. Then came the automated cells counters, and the basic principle on all of what the automated cell counters initially worked on and still use are the Coulter principle. So whenever the blood is aspirated in an automated cell counter, it gets divided into two chambers. One is the first chamber where the RBCs and the platelets are counted together, and the second chamber where the RBCs are lysed and only the WBCs are counted. Whenever a cell passes through the aperture in one of the membranes, there's an increase in the resistance leading to electrical impedance. This electrical impedance then leads to a voltage pulse, which depends on the size of the cell. And this the cell is then counted in a particular window. So this number of pulses is directly in relation to the cell count. So the Coulter principle was able to differentiate the cell on the basis of the cell size, but there are some cells in the blood which are of similar size, like the various WBCs, the neutrophils, that is the neutrophils, eosinophils, and the basophils. So we would use additional methods to differentiate them, that is the scatter, that is the granularity, and the conductivity or the density of the cell. But here today, as we are dealing only with the platelet count, we'll learn a little more about the principle. So when the blood is aspirated in the RBC and the platelet chamber, the platelets are counted between 2 to 20 femtoliters. And the window generally in most of the automated cell counters is between 2 to 30. So what happens is when we are dealing with any kind of interferences, that is something which is there is a contamination in the blood, that is a EDDA particle or the dust, and it is less than 2 femtoliters, it still might be counted in the platelet window, leading to a spurious count. And anything which is a little overlapping in the 20 to 30 femtoliters may again be counted in the platelets, like the small RBC fragments like schistocytes, microcytes, as well as WBC fragments. This is how the voltage is produced. This is a voltage pulse produced by an RBC, which has a higher amplitude because the number of RBCs in the blood are much more than what the platelets are. These are the pulses produced by the platelets, and this is how the graph is produced. And we can see there is always an area where the overlap between a platelet and the red cell can occur. The gold standard method that is given by the golden standard reference method used for platelet counting is basically the international flow reference method. So in this, we use a dual platform. We use count the platelet events divided by the RBC events counted on the flow cytometer and multiplied with the RBC count from the automated cell counters. And any method of platelet counting today is compared to this method to give you the right accurate platelet counts. So it also includes measuring the presence of antigen on the platelets, the flow cytometry. So you use 42B to measure glycoprotein 1B on platelets and 4161 to measure glycoprotein 2B3A on the platelets. Every hospital has its own protocol for informing platelets, low platelet counts in IPD and OPD, and our hospital has a strict protocol. We being an accredited lab have a SOP, how do we report out the platelet counts. So first and foremost, a delta check is done for every indoor sample being received. So for all the three parameters, that is the hemoglobin, the WBC, and the platelet, the previous counts are matched with the sample counts received today. For samples with a platelet count of 1 to 50,000, we check for the sample for any clot, and we mention that on the batch printout saying that the clot has been checked and no clot is seen. Then a smear is made, and on the smear, if there is the presence of clumps of fibrin stand, a repeat collection is asked in sodium citrate or EDTA to see that there are no clumping seen and a correct platelet count is given. If large platelets are seen, which are with no clumps in the platelet in the peripheral smear, we do a fluorescent platelet count or an optical platelet count to give a more accurate platelet count. And all of this should be done within minimal delay because most of the patients in our setup are oncology patients and the platelet counts are urgent for these patients. Coming to some case studies, and these are all real life cases. So we had a 56-year-old gentleman who came to the OPD for a pre-operative assessment. And the platelet count was found to be 1,04,000. Now, this gentleman also said that he's never had an issue with his CBC counts. And a count of 1,04,000 was not expected by the patient nor by the clinician. We had seen the platelet histogram, and we found that the platelet histogram did not lie in the normal range. The amplitude of the peak of the pulse was lower than the normal, and it was also not touching the baseline. We went to the smear examination. The smear examination of the patient, we saw that there were many platelet clumps in the tail end. So smear examination is very important. So many clumps were seen in the tail end. And this was reported as platelets seen in many clumps. Platelets are adequate on smear, that is more than 1 lakh. And to repeat the CBC with citrate collection for accurate platelet estimation. This is the comment we generally give in any PDTA platelet count which we get, which is on the lower side, and we are seeing clumps. The patient citrate collection came to us, and we found the platelet to be 3,27,000, which was more than adequate. And now you can see the graph is also lying within the normal range. A second case, a 27-year-old male patient, a blood donor from East India in origin, that is, he was from West Bengal. And we saw the platelet count of this patient was 1,01,000. Now, the thing is that there is something called as a Harris platelet syndrome or a constitutional macrothrombocythemia, which is seen particularly in patients in the East, in West Bengal, Orissa, in this region, where the platelets appear to be larger than normal. So here we see the graph. The graph is not again reaching the bottom or not touching the base. And there is something which is lying in the RBC region, which is then the graph is extending to that region. We went back to the smear and we found these large platelets seen in the smear, the large or the giant platelets, which were there, and there was a low count given. We went ahead, did a fluorescent count. We found the platelet count to be 1,36,000. So platelet counting has to be done beyond impedance count. You have to do the smear examination. And now the new end machine, the new machines also have this method of counting platelets by the optical method or the fluorescence method. So what happens in the impedance, like I showed you, there is always a possibility of an overlap. In the optical method, the platelets are counted in the reticulocyte channel, where the RBCs lie in a different area and the WBC and the platelets are counted in a different region. They do not overlap. Even if there is any fallback of these small RBCs, they come in a region where there is no overlap with the platelets. So because of this, the counts given by these machines is more accurate than the impedance count. So in the XE series, we have the optical platelet count, which is given within the retic channel of the system. While the XN series of the Sysmex, it also has additional channel only for platelet count, which is called as the Platelet F, which also gives out the IPF or the reticulated platelets. Here we can see that the RBCs lie in the top region. Even if there are any microcytes or schistocytes or any overlap coming from the RBC region, it will not be falsely counted in the platelets. This is a comparison showing you what I just showed you, that the RBCs, the extension, this is what we see in the impedance counting. There's an overlap. Whenever you have a giant platelet, it will fall into the RBC region and might not be counted as a platelet. While in the RBCs, if you have the microcytes or cellular fragments, which may be counted in the platelets, giving a spuriously high platelet count. While in the optical counts, this is avoided because there is no overlap in the two regions. In the platelet F channel, the platelets are basically labeled by a fluorescent dye using oxazine. And when they're labeled by a different nuclear dye, it helps in giving an accurate platelet count. It also gives us an immature platelet fraction, which is the reticulated fraction platelets or the immature platelets. So where did the fluorescent F help us with the platelet counts? We had a 22-year-old male who was a newly diagnosed case of acute myeloid leukemia with a very high WBC count of 2,98,000. You can see in the graph here, these are the atypical cells which are forming a cluster, and they are lying in one region itself. The platelet count of this patient was 1 lakh on impedance. We got a call from the clinician saying that clinically he's not expecting a platelet count of 1 lakh, and the WBC count of this patient is too high. We went and saw the histogram. We again found the amplitude was not reaching its height, and it was also not touching the base, meaning that the platelet count might have, which has been reported by the impedance method, might have not been accurate. We went ahead and saw the smear, and what we found was that these are the cellular fragments which we see in these sometimes in patients with high WBC count, especially in leukemia cases, which break out from the WBCs. And because they do not have any nuclear material in them, they might be falsely counted in the platelet region, giving a false high platelet count. We went ahead, did the platelet type of this patient. It was 55,000 only. A 27-year-old male on chemotherapy. The case 4 was a 27-year-old male on chemotherapy for AML. And we found a platelet count of 60,000. Now, this patient was an indoor patient in which we have been doing the delta check, and the patient's platelet counts were always less than 20,000. So a 60,000 platelet count was not expected by us, nor by the clinician, because one day we have a platelet count of 18,000, they have not transfused the patient, and the count has suddenly jumped to 60,000, and the WBC count and all the other parameters are on the lower side. And we see the graph that it is again not regular. There is no pulse, there's no pulse being generated, or there's no curve being formed, and it is going into the RBC region. We see the smear. What do we find? We find a lot of these fragmented RBCs. We see these microcytes, and we know that the machine might have ended up giving us a false high platelet count. We go back, do a fluorescent platelet count, and we find that the platelet count is 3,000. We also, whenever we do a fluorescent platelet count, we also do a manual count on the smear to check that what we are seeing on the smear is similar to what the machine, the fluorescence is giving. Here you can see the graph. There is some in the platelet F region, there is fall down from the RBC region, which would have included the fragmented RBCs. Then coming to a case in which a 48-year-old male, he came to us saying that I have different platelet counts in various labs. Some lab gives me a count of 2 lakhs, one lab gives me a count of 3 lakhs, one lab gives me a count of 1 lakh. So I wanted to check what my platelet count is. The platelet count in our machine on impedance came as 1,50,000. The graph, again, the curve is not touching the normal. And when we saw it on the smear, we see that there's a particular phenomena which is seen with the anticoagulant EDTA. So there is, which is called as satellism. The RBCs tend to gather around the WBC, and this causes pseudothrombocytopenia in the patients. So thrombocytopenia is reported in about 0.1 to 2% of the population. And it is caused by antiplatelet autoantibodies that cause the platelets clumping in the blood, which is anticoagulated with EDTA. The sixth case, a 79-year-old male who was a known case of myelodysplastic syndrome / myeloproliferative neoplasm with the mutations present. He had the platelets of the patient were 4,07,000. And the graph, again, though the counts of the patient were within the normal range, we saw that the graph of this patient on the platelet is not touching the baseline, is overlap and going into the RBC region. So there is a possibility that this count might be on the lower side or falsely lower side. The peripheral smear examination of the platelet of the patient showed giant platelets. So what is a giant platelet? Anything which matches the size of the RBC or a small lymphocyte. There were giant platelets which were basically overlapped in the RBC region and had not been counted by the machine. We found on a manual platelet count, the count to be around 6 lakh in this patient. And on a platelet F, we found the count to be 6,34,000 of the patient. And here I can show you that there were a lot of the IPF of the patient, or the immature platelet fraction, was also very high. And there's an increase in the reticulated platelets of this patient. So these were the cases in which using a fluorescent platelet count or making the smear and doing the delta check helped us know that the impedance count given by the machine could be false or spurious, and we need to check the smear to know what the accurate platelet counts are. So what are the causes of spurious increase in platelet? Is the presence of cryoglobulins. So in patients where the cryoglobulin particle itself might lead to an increase, a spurious increase in platelet count. When there is hemolysis in the patient, there are many microcytic red cells, there are red cell inclusions or white blood cell fragments, which can lead to spurious increase in platelet counts. And the spurious decrease could be seen in patients which show clotting, or where there's overfilling of the sample leading to inadequate mixing and formation of clumps. Giant platelets, heparin being used, and platelet satellosis or platelet clumping can also lead to spurious decrease in platelet counts. So how can you troubleshoot all this? Is that always when if you are doing a platelet count and it does not clinically match with the counts that you have been expecting the patient, or there's a call from the clinician, always check the peripheral smear. When there is a flag, most importantly, when there is a flag in your automated cell counter, where you will see that, the flag is like platelet clumps seen, fragmented RBC seen, or there's a abnormal platelet distribution. So that is the time when you have to check for the peripheral smear and see, and especially check the periphery of the smear, where the clumping on the sides and the tail end where the clumping actually happens. Always in onco patients on therapy, always rule out a microclot in the sample. Look for fibrin stant and platelet clumps on the side. Do a peripheral smear estimation of the platelet count to give an accurate platelet count. And be aware of the fact that clinical decisions would be made on your result, knowing that knowing the transfusion threshold. Like in our patient who was on chemotherapy, the platelet count, though being reported from 60,000 to 3,000, changed the clinical decision of giving the transfusion to the patient or not. Avoid platelet transfusions if possible, and always discuss the case with your clinician. So whenever we see fibrin strands or platelet in the end, they might have enmeshed plateletism. And so we always look for a clot in the sample. How do we do that? Is that we transfer the sample from an EDTA tube to a plain glass tube to see any clots in the sample. And sometimes we also find microclots attaching to the sides of the tube, which would be the presence cause of the false low platelet counts being given. This is a slide telling you the difference between an impedance, optical, and fluorescence platelet count. So impedance count is basically uses the impedance method, while the optical and the fluorescent count use specialized dyes to give us the accurate platelet counts. These equipments, these impedance counts is generally not affected by microcytic RBCs. Impedance count is generally affected by microcytic RBCs and debris, while the optical and the fluorescent counts are not. But definitely the optical and the fluorescent platelet counts are have a higher cost because the equipments are of the a little higher end, and they have maintenance costs too. This is a list of various automated analyzers which use the different methods to give you the accurate platelet count. And in our lab, we are using the Sysmex series, which gives us the fluorescence count. In addition to the platelet count, the automated analyzers also report out the mean platelet volume. What is the importance of this mean platelet volume is that it tells us if the marrow is active or not. So in cases where the platelet counts are on the higher side, the MPV the MPV is on the higher side, more than 12 ml. It is basically because the platelets being produced by the marrow are more. So increased MPV is seen in cases of immune thrombocytopenia, myeloproliferative neoplasm, constitutional macrothrombocythemia, and hyperthyroidism. While decreased platelet is when the decreased MPV is seen in cases where the marrow is a little on the suppressed side, like in aplastic anemia, liver cirrhosis, and inherited platelet syndrome known as Viscott-Aldrich syndrome. In addition to the platelet counts, we also report out image of platelet fractions given by the fluorescence method. And this image of platelet fraction is reported as a number, as a percentage, as well as an absolute number. It shows us the young platelets or the reticulated platelets in the bone marrow, in the peripheral blood. And IPF is high when there is peripheral consumption or destruction of platelets, as seen in cases of ITP and TTP, indicating an active bone marrow. While in bone marrow aplasia or in an aplastic marrow or a suppressed marrow in post-chemotherapy, the IPF might not be on the higher side. So a study for the importance of IPF, which we routinely use even today in dengue patient, was done in the hospital. And in this, what we found was that when a serial follow-up of dengue patients was done with the low platelet count less than 150,000, there were certain significant findings which were found in this study. Is that whenever IPF, we studied in this study, we basically checked for the IPF reaching a peak value, the rising trend, the falling trend, and when the IPF crossed 10%. So it was found that the IPF was increasing till the platelet count dropped. And once the IPF reached its peak, that was after which the platelet recovery started happening in the patient. So here we can see that it was found that that patients, once the IPF peak was reached, patients, which were 84% patients recovered their platelet counts within 24 to 48 hours. In the rising trend of the IPF, the recovery of patient recovery, though the 90% of the patients recovered within 24 to 48 hours, the recovery was seen up till the 4th day. But when a falling trend of the IPF was noted, there was a recovery within 24 hours in the platelet count. And if a single IPF value of more than 10% was documented, it was found that most of these patients recovered the platelet counts in 72%. So why is this important? Because in dengue patients, we see a rapid fall in the platelets, and we have clinicians asking us that will the platelet fall further. We generally advise doing a serial IPF in these patients to see what is the trend of the IPF. And if the falling trends of the IPF begin, then we are sure that the platelet recovery will happen from the next day or within the next 24 hours. This was the automated cell counts. So automated cell counts are good, but microscopy has to be compared with these automated cell counts. And the lowest, Henry Abuk writes that lowest manual platelet count should never be reported less than 7,000, because after this, the coefficient of variance is very high. So the lowest platelet count on a manual count should be not less than 7,000. The platelets, various kinds of platelets are on the scene on the peripheral smear, small platelets, large platelets, and giant platelets. Now, because most of the labs would not be having these high-end machines where you can do a fluorescent count and an optical count to give the right platelet count, the microscopic or the manual estimation of the platelet count is very essential. Though it is not standardized, we need to know what kind of microscope you're using in the lab, know the field number or the field number of that microscope, and divide it by the magnification that you're using. So like we are using a Olympus microscope with a field number of 26.5, and dividing it by 100, we know that the field of vision for our microscope is 0.2, and the appropriate multiplication factor after doing 10 high power field counts of platelets, we can use as 15,000 by the average of those 10 fields and then multiply it by 15,000. That is what most of the people do for manual estimation of platelets counts. So you have to standardize that manual estimation in your individual lab by doing an exercise to see which counts give the most comparable counts to the automated cell counter. Now coming to a case history. So a patient came to us, an 8-month-old boy with history of bleeding from the injection site, which was noticed after last vaccination. There was prolonged bleeding seen for 30 minutes, and the patient had no significant family history. All his CBC parameters are normal. So how do we proceed from here? So we start, and so we come to the question, what is an inherited platelet disorder? So whenever there is a bleeding phenotype, despite normal screening tests for hemostasis, bleeding disproportionate to the degree of thrombocytopenia unresponsive to the ITP therapies, we have a syndromic approach where a lot of relatives are affected, and we know that this patient might have a bleeding disorder. That is when we go ahead with the platelet function disorder testing. We do the clinical evaluation of the patient, take the personal and the family history. If it is normal, no further studies are required. If those clinical evaluation, he has a positive family history, he has the BAT score of more than 4 or 5 in adults, then we go for the routine coagulation testing and the von Willebrand factors. If those are abnormal, then we can think of a deficiency of a factor or von Willebrand factor defect. If those are normal, then we think of a potential platelet function disorder, and then we see the CBC of the patient to see if the platelet count is normal or it's on the lower side. If it's on the lower side, we can think of ITP. If the patient platelet count is normal or low, then we can, and there's a bleeding increase in bleeding time, then we can go ahead with the platelet function test that includes light transmission aggregometry. So platelet function disorders are classified by the size. That is, small platelets like in the Wiskott-Aldrich syndrome. Normal side platelets are seen with various other syndromes, and large platelets are seen with Bernard-Solier syndrome, gray platelet syndrome, type 2B, von Willebrand disease. These are the microscopic pictures of a small platelet. These are the normal size platelets, and a large or a giant platelet. So when is the platelet called a large platelet? When the size is more than 11 femtoliters, and it is giant when the size of that platelet is similar to that of a RBC. We have a platelet with absence of granules, which can be seen with gray platelet syndrome. This is a classification of the inherited platelet syndrome on the basis of function of the various platelets. So if you have a defective adhesion, that is the defect in the defect in the von Willebrand factor or absence of glycoprotein 1b, the patient can be diagnosed with Bernard-Sollier syndrome. If there is defect in aggregation of the platelet, like this glycoprotein 2b3a, or in the then the patient can have Glanzmann thrombocythemia. And if there's defect in the release from the granules, we have the gray platelet syndrome, the Wiskott-Aldrich syndrome, the Hermansky-Pudlak syndrome, and the Chidiac-Higashi syndrome. How do we differentiate between in patients with abnormal bleeding, whether it's a platelet defect or a factor deficiency? So we have to have an overview of the bleeding event. If there is more of mucocutaneous bleeding, then it's a platelet defect. If it's a deep tissue bleeding, then it is suggestive of a factor deficiency. Excessive bleeding after only minor cuts, again, platelet defect, which is not seen with factor deficiency. Petechiae are more common with platelet defects, less common with factor deficiencies. Ecchymosis, which are small and superficial, suggestive of platelet defect. Large subcutaneous soft tissue bleeds, again with muscle hematomas and hematorosis, are suggestive of factor deficiency. And bleeding following invasive procedures or surgery. If it is immediate bleeding which is seen, then it is suggestive of a platelet defect. If it is delayed, then it is suggestive of a factor deficiency. In our hospital, what are the pre-requirements that we require for a patient when he comes for a platelet function testing? So the patient should be off all kind of medication for at least 4 days prior to the test. We had to report the test in the morning after fasting overnight. And we have a lot of children who also come for this testing. So even if a 6 to 8 hour fasting period can be given for the children, it would be good because it gives a more accurate result. The meal taken in the previous night should be on the lighter side. It should not contain any platelet activators like spinach or green leafy vegetables. After the sample has been collected, we generally take a detailed history, a family history, a drug history of the patient. A coagulation screen for PT-PTT is done to rule out coagulation defects. And blood is collected in 3 to 4 citrate tubes, centrifuged to get a platelet-rich plasma, in which the platelet count should be somewhere between 2 to 3 lakhs. The bleeding time of the patient is done using the template method or the Lancet. So in this, a standardized cut is given in the volar aspect of the patient, and the bleeding time is done using the plotting paper. Prolonged bleeding time done properly can be indicative of a polylative platelet function defect or von Willebrand disease. This test is not done in children less than 2 years of age or with a platelet count of 20,000. We have to ensure that the depth and the location of the cut is standardized so that we get the accurate results. A too deep cut or a too shallow cut could give us false results. Then a platelet function analyzer, the blood is also used in which citrated whole blood is used. It has to be performed within 4 hours of collection. So what is done in this study is that basically blood is aspirated at high shear rates through disposable cartridge, and there's an aperture in the membrane which is coated with the agonist, that is collagen, epinephrine, or collagen and ATP, and the time taken to leading to the closure of this aperture is counted as the closure time. So these closure times are generally increased in patients with platelet function defects. And again, we have to ensure that the lab part of it is all standardized with where we are sure of the no history of antiplatelet drugs or low counts in the patient before we perform this test. The gold standard of platelet function test remains platelet aggregometry, in which the platelet function is seen with various agonists, that is ADP, collagen, epinephrine, and histocytin. So it helps to measure the platelet aggregation to various agonists. In it, there's a light source which emits light that is measured by a photocell. So the platelet-rich plasma of the patient is stirred in a cuvette at 37 degrees Celsius, and then that cuvette is made to sit between the light source and the photocell. Once the aggregation starts, initially there'll be no light which will pass through the photocell, but once the aggregation starts, more and more light will be passed, and that is recorded as a graph. So the strong agonists used are collagen and arachidonic acid, and while the weak agonists are the ADP and the epinephrine. These are the various lab factors which can affect the platelet aggregation. That is, the centrifugation has to be done at the right rate. The time after which the platelet function test has to be done is within 30 minutes of preparation of the PRP. The platelet count ideally should be more than 1,50,000. Even a count of more than 1 lakh is enough for us to do a platelet function test, but generally a platelet function test is not done below 1 lakh count of the patient. The hematocrit of the patient should be normal, because increased hematocrit could lead to increased concentration of citrate in the PRP, leading to again abnormal aggregation. And the other things are the temperature of the lab when the test is done should be optimum. There should be no dirty quivet, no air bubbles when you're performing this test. So it has a lot of you have to be very sure of your lab parameters before you report out this test. So in Bernard, what are the various reactions to various agonists which we see in various defects? That is, like in Bernard-Soler syndrome, the abnormal aggregation is seen to ristocetin. In Glanzmann thrombocythemia, there is abnormal aggregation seen to ADP, epinephrine, collagen, while it is normal for ristocetin. While in fact, von Willebrand type 2 disease, there'll be decreased aggregation seen to thrombin and increased aggregation seen to ristocetin. That is the low dose ristocetin. So that we do ristocetin in 2 concentrations. So the low dose ristocetin aggregation will be increased in this case. Coming to some platelet function defect cases. So interesting cases. So we have the first case which I told you that there's an 8-month-old boy with history of prolonged bleeding post vaccination. So the factor levels of this patient were all within normal range. His PT, PTT normal, TT normal, but the closure times was prolonged. Initial workup showed a normal CBC with a BAT score of only 2 and platelet count of 3,97,000. The prothrombin time was and the PTT of the patient were within the normal range. When we did the light aggregation testing, we found that the patient showed normal aggregation only to ristocetin, with the absence of aggregation seen to ADP, collagen, and epinephrine. Flow cytometry done on the patient showed the absence of expression of 41 and 61 in the patient, with normal expression of 42B. And this patient was diagnosed as Glanzmann thrombocythemia. In a second case, we had a 12-year-old girl with history of epistaxis at 3 years of age, with cutaneous bruises and bleeding, and history of gum bleeding. She also did not have a positive family history of bleeding disorder, and she was the firstborn to consanguineous married parents. On the initial workup, we found the BAT score to be 11, which is on the higher side. The platelet count was 26,000 on the impedance, but on the fluorescence, again, we found the platelet count to be around 90,000 to 1 lakh, and he proceeded with the platelet function test. The bleeding time of the patient was more than 15 minutes, and the PT of the patient was slightly prolonged. The factor levels in this patient were within normal range, and the closure time was prolonged. While on platelet aggregometry, we found that the patient had normal aggregation to ADP, collagen, and epinephrine, while reduced aggregation was seen to ristocetin, suggestive of a Bernard-Soler syndrome. We went ahead with the flow cytometry, and we found the expression of 42B to be absent on the platelets. After getting them on the forward and side scatter, we found, and these platelets were positive for 4161, while being negative for 42B, suggestive of a Bernard-Soler syndrome. A third case is a 10-year-old girl presented with history of epistaxis, history of menorrhagia in the mother, with a BAT score of more than 15. The platelet count was borderline low, that is around 96,000. The bleeding time was prolonged. On light aggregometry, we found that even there was normal aggregation seen to ADP, collagen, ristocetin, and even low dose ristocetin showed us a normal aggregation, suggestive of low dose ristocetin induced platelet aggregation, which is seen in platelet type von Willebrand disease or von Willebrand disease 2B. So after telling you about all the cases on an automated cell counter and about the platelet disorders, I would like to say that precision in platelet testing is not just a technicality, because your counts make a difference in the patient management. Every precise platelet count is just not a number, it's a direct influencer of patient outcome. Blood smears or peripheral smear examination along with the automated cell counts are essential for abnormalities flagged by any automated system. We also now have to take care that the pre-analytical variables while testing for platelets are not affected when we are giving a platelet count. So the EDTA blood samples are stable for about 5 hours at 20 degrees Celsius and 24 hours at 4 degrees Celsius. Improper collection or mixing of the sample also can lead to erroneous counts, and you have to be sure that when the collection has done, there has not been a delayed collection or a prolonged collection leading to the formation of clumps. And all the instruments on which you're doing the platelet count are functioning properly and have proper calibration. So quality control is just not a checkbox, but it's a vigilant guardian against any kind of errors when we give out the platelet counts. I would like to thank Dr. Shanaz Kudaiji, my mentor, and in Hinduja, and my staff for all the help they have given me. Dr. Khushbu, Ms. Benu Jacob, our supervisor in collection of all these cases, and Dr. Neha Seth for helping in conceptualizing this presentation. Thank you.
Yeah, wonderful talk, Dr. Vidisha. It was really enlightening one. So, any questions from the audience? See if anything is there in the chat box. Antish, any questions from the audience?
Good afternoon. I'm Dr. Vishwadeep. Am I audible?
Yeah,
Yes, Dr.
Vishwadeep.
Vishwadeep.
Yes. So, ma'am, actually, I've covered everything in so detail that there are no confusions left actually. So, routine things which people don't know, we have covered that all very precisely and exhaustively also. Like, it's very difficult to be precise and exhaustive both at the same time. So, that was a very wonderful talk. Majority of the concerns are clear. I would just
Yes.
have an opinion regarding, like, as we interpret retic, there is a clear-cut idea like how to interpret retic if it is 10. You touched upon IPF. Could you elaborate in slight detail, like IPF? Is there any range or cutoff we should follow,
Yes.
and whether it should not be followed?
So the IPF, the immature platelet fraction, is you can first of all you can derive your own range for the IPF, and the normal IPF ranges are generally up to 6 or 7 in our lab. So anything which is more than that would be indicative of more of a reticulated platelet. IPF is more accurate than mean platelet volume, which are reported in low counts. But again, an IPF in a patient count of less than 10,000, we should be it's not that accurate, but yes, we can give an IPF. So this becomes especially important when you're talking about patients who are suffering from dengue. We get routine calls. You have patient admitted, platelet counts are less than 20,000. Do we need to go ahead with transfusion other than seeing the clinical details of the patient also? So if we are the IPS is more than 13.5 or more than that, we generally would tell the patient the clinician to hold on for a transfusion, watch for another 24 hours. If the IPF goes down further and it's not increasing, then we would be worried. And we have derived our own ranges in the lab for IPF.
So you are saying about fraction, percentage or absolute number?
This is the percentage.
Okay. So, but what I've noticed is percentage can be like significant, but absolute number I have no reference in. So I don't know whether it is like good or
I think
bad.
more studies are required to we have studies which basically tell us about the percentages. Yes, about the absolute, we still have to find the right ranges where we can call them clinically significant.
Thank you. Like as in like many times on routine work, like when the new aplastic comes or maybe we are suspecting hypocellular marrow, and in that case, would absolute number matter, like as we do in automated retic count or retic count as such, to label a plastic?
Aplastic, we generally see. I have not seen on the absolutes, but yes, on the IPF in the percentage wise, yes, it's on the lower side. The IPF will be on the lower side in such patients. In aplastic, it's a very good way of telling you is the marrow active or not.
Thank you so much, ma'am.
Yeah.
Good afternoon. Am I audible?
Yeah, Dr. Richa.
Yeah, hi, Dr. Vidisha. Wonderful talk, very beautifully summarized everything, and it was indeed a very good revision of all the basics. My concern is about quality control. As you correctly mentioned, that the lab should be very judiciously following the quality control protocols. But really, the IQC and ECAS we are practicing, they are not stabilizing the samples for the low levels, which are actually clinically relevant. So that was something I wanted to discuss with you. And other thing, are you practicing ECAS for platelet F and IPF?
Yes, so we are a CAP accredited lab, and we do report out our platelets with the CAP and the IPF and the this retic is the retic counts are given, and talking about the low platelet counts, yes, there always will be a space for discussion on that, because low platelet counts, one thing is that as our books write that anything less than 10, generally if a platelet count appears to be less than 10,000, an automated count, it should be reported as such. And you should not be mentioning a platelet count of 2,000, 3,000. You can always mention it as, like I said, Henry writes a cutoff of 7,000.
Right.
And to ensure that the lab or in fact the internal way of quality control in these low platelet count is that you can rerun a sample which is on the lower side 5 times to see what variation your machine gives in that. That also can help you with the quality control of these samples.
Yeah,
Basically.
and sometimes the inter-instrument one also helps.
Yes. If you have 2 instruments, yeah. Generally, people will with one instrument can do is that they can do repeat runs of the same sample to see what variation your machine is giving on a low platelet count. And if you have had 2 machines, like we also have 2 machines, we have a Coulter and we have a Sysmex. So we'll see what is the inter-instrument variability.
Yeah.
And have low cutoffs for that. So
for platelet F, you are getting ECAS from UK NICAS?
Yes.
Fluorescent platelet?
Yes.
Okay. And the other thing was many of the labs, they may have access to automated retic count. We are also having Sysmex. We are doing both platelet F channel and the ARC, but many labs may not have activated platelet F channel. So your experience with concordance between platelet optical and fluorescence on Sysmex, because literature says they are quite good. So even if you don't have platelet F, like in our setup, we have junior residents every 6 months changing. So having at least platelet O also helps. That is my experience in lower platelet counts.
So the basic principle between an optical and a fluorescent count remains the same. Both we are using an external dyes to label the platelets in both. The only thing is that fluorescence, you have a specific channel in which the fluorescent count is done. So while the optical count is done in the retic channel itself, right? So, but the concordance between both O and F is supposed to be very good. And especially, I don't think many labs would be using even we would be using the additional reagent. So there's a there's a reflex testing in these Sysmex machines, that if the AI in the machine thinks that the impedance count is wrong, then it will go reflexly onto the optical count or the fluorescent count, which it finds appropriate and report out that count, which is labeled as an AND symbol on the CBC machine. So you can enable that also while reporting out your platelet counts.
Yeah. Considering the cost in government setup, we are charging patient is very, very low. We haven't made it reflex, but the pathologist decides if we need, we run it on ONF. Otherwise,
we do the same. We do not go on the reflex. We generally do the delta check. We'll see for low platelets. Still, it's consistent with that, and then we report it accordingly.
Yeah. Thank you so much. Wonderful talk. Thank you.
Thank you, Dr. Richa.
I think Nikhil Kumar has some question.
Yeah, Dr. Nikhil.
Excellent talk, ma'am. From a clinician's perspective, you have covered all the topics so well, and many of those places where we have gray areas or confusion, you have touched upon all of them. I just have a couple of questions. You mentioned that when doing a platelet function test, at least a platelet count of 1 lakh is desirable. But what is the minimum platelet count below which you say, no, we will not do a platelet function test, or there is no utility in doing it? Is there any cutoff like that?
1 lakh. 1 lakh is a standardized cutoff which is being used by all the labs which are using the doing the platelet function testing by light aggregometry. Flow cytometry does not have that limitation. So even a low platelet count on flow, we can go ahead and tell you if the patient has at least Glanzmann and Bernard-Solon. But for LTA, we generally have a cutoff of 1 lakh. Because then otherwise the chances of giving a false result would be very high.
Right. And my second question is many of the patients, especially the pediatric patients who are labeled as a refractory ITP, go on receiving multiple lines of treatment. Do you think before labeling them as a refractory ITP, a clinical exome sequencing or a genetic test should be done? Because many of them end up having a inherited platelet disorder or some
which are
mutations like RUNX1, which many of the times are not missed. So, in your practice, where would you place exome sequencing or an NGS in the evaluation of platelet disorders?
so yes, if you are not getting an answer on after doing all the tests which we have shown, then an NGS and the patient still has a persistent low platelet count and you've done a bone marrow examination and the megakaryocytes appear to be adequate and it's everything is fine, then I think an NGS needs to be done in such patients to rule out any kind of genetic mutation which is leading to the low platelet counts. But
Thank
that
you.
is after you've done all this.
After the basic.
Yes.
Thank you.
Thank you. Yes, Dr. Kunal.
Good morning, ma'am. Excellent talk.
Thank you. Thank you.
My question is about ADT-induced thrombocytopenia. I have
Yes.
seen a couple of cases when we are sure that it is ADT-induced thrombocytopenia. Platelets are low on counter. We get clumps on PS, but it is not corrected by citrate tube.
So we also face this in a daily practice. And in that, yeah, so we do have this lot of patients who come in when we have us on ADTA, we have a pseudo thrombocytopenia, and unsighted again there is a clump. So in that case, if you're finding the clumps to be large enough, like the ones I showed in my case, you can always tell the clinician that the platelet count is adequate. It's more than 1 lakh, and there's clumping in the sample, and it could be repeated at a different point of time in which both the EDT and citrate are collected together. So I think if the patient and the clinician both know that the platelets are adequate, it was only because of a lab reason or the collection reason that there's low platelets, I don't generally works. And then they repeat the sample, after a month or 2 months time before we can get an accurate platelet count. But it's a very common scenario. We do get clumps even in the citrate.
Thank you.
But you have to talk to your clinician to make sure that they understand that the platelets are actually adequate on the smear.
Thank you.
Thank you.
Yeah, ma'am, we have some questions from the audience. Just tell, Babita Sodhi has asked, Madam, what is the difference between large and giant platelets?
So a large and a giant platelet, like I showed, is basically the size and the difference. So a giant platelet is something which we call when we see the platelet size to be an equivalent to an RBC or a small lymphocyte. That's called a giant platelet. And something which is smaller than that, but normal. The ranges are given by size wise. Like says up to 7 femtoliters, you have a normal platelet. From 7 to 11 femtoliters, it's a large platelet, and something beyond that is a giant platelet. So you have to see it relatively when you're seeing on microscopies, compare it against an RBC or a small lymphocyte. If it's matching the site, then it's a giant platelet, is something smaller, but no, bigger than the normal looking platelet, then can be called as large platelet or macroplatelet.
Yeah. I think Dr. Upendra Sharma has some question on the discussion.
Thanks, Dr. Vidisha, for that wonderful talk. I'm wondering what to ask for you because you have covered most of the topics or most of the points in your topic. So, in patients of, say, hypertensionism, wherein patient has, because of the sequestration of the platelet into the spleen, patient having low platelet count. So, what do you think that in immature platelet fraction in those patients should be because immature platelet fraction is indicative of the marrow production. So if marrow is more proliferative, IPF will be more. If marrow is say aplastic non-proliferative, then it will be low. So what will the IPF in those circumstances?
So the IPF, according to if there's a sequestration, and then we are expecting the marrow to be more active. So in that case, the IPF should be on the higher side in such patients.
But because of the marrow, because spleen is sequestering these platelets.
Then the marrow tries to compensate by producing more of these platelets. So that time the IPF would be on the higher side. Yeah, you will do whenever there's excessive destruction, excessive sequestration of platelets. There's compensation from the marrow side, so then you do get IPF on the higher side. We get IPFs of 35, 40 in such patients generally.
Okay.
Yeah, we have some more questions, ma'am. Raj Warrior has asked, sorry to say that bleeding time should not be done in any children, irrespective of the age, not done by any peds docs anymore.
Okay.
Very inaccurate too. Can you?
So yeah, that is what I mentioned. Generally, it is recommended not to be done less than 2 years of age. But if you have a standardized lancet, you have a one which goes to a proper depth, then I know there is a lot of subject variability, but if you're standardized in your lab and you're confident, it does give us information about the, it is not, it is, I know that in children, it would not be, most of the patients would not be doing it, but if it is standardized in your lab, it does give information if the patient has a prolonged bleeding time or not.
Another is, could you comment about the use of commercially available genetic panels for many platelet and hereditary bleeding disorder? Lot faster and easier and more accurate.
Yes, so this is, like I said, if we are doing the screening for all these platelet function disorders and you still do not get an answer for a low platelet in a child, then we can go ahead with these genetic panels for diagnosis.
Another question by Hita is, madam, have you come across any acquired platelet function disorder?
So acquired platelet function disorders is what we generally see with as a drug-induced platelet disorder. So in such patients, even if like a patient who's been on antiplatelet drugs or any kind of NSAID, we've seen that a patient on even on paracetamol, you will get a low, though they say it does not affect collagen, does not affect arachidonic acid, you will get a low collagen and a low arachidonic acid. The patient should be off the drug at least 4 to 5 days before you do the platelet function test. And this is the most common cause of a false positive platelet function test in our lab. So it is most of the time the patient is or has been on a drug, stopped only for 2 days. We go ahead with the testing and we find that the ARAC and the collagen are on the lower side. And that is the most common cause of acquired platelet function test that I've seen, platelet defect I've seen.
Dr. Savitri has asked, any effect on platelet count due to high lipemic sample or due to cryoglobulins?
High lipemic sample, cryoglobulins, yes, it can lead to spurious increase in the platelet counts where the cryoglobulin particles can lead to the increased count. Again, there the smear examination does help. And even high lipid, I have not come across a case, but they say patients which have abnormal, very high lipid content can also give you a spurious high platelet count. So again, your smear becomes very important. And if you have the specialized ways of platelet counting, that is the fluorescence, the optical, you can always opt for it, because here the machine will directly have dyes which will attach to those platelets.
Yeah. Again, she has asked, in aplastic anemia, they have observed that many times MPV is on the high, cannot explain.
That
Any cause? Because
yes.
many
So
MPV
again,
try to
it is documented that MPV is less accurate than IPF in low platelet counts. So if MPV can be spuriously high, because the number of platelets being counted by the machine would be far less. And if they are on a slightly larger size, then the MP would be counted as more. So it should actually be low on the lower side. So these are the false positives that you can expect when you're dealing with low platelet counts.
Yeah, when Dr. Vinayak has asked, is bleeding time reliable?
So as someone said, in children, it might be difficult to standardize. Yes, bleeding time, we do it as a routine when we have a platelet function test is ordered in our lab. And we have seen that in actual platelet function defects, the bleeding time is prolonged. So if you have people who are properly trained, who know how to use a lancet, and you give the right kind of incision, it can be helpful in actually diagnosing a platelet defect. And the way things are going, I think it might slowly become redundant, but it's still being used in clinical practice.
Dr. Vishwadeep has asked, any panel to suggest for working up macrothrombocythemia by NGS based?
Constitutional macrothrombocythemia. I am not aware of any particular panel for such constitutional macrothrombocythemias.
One next question from Dr. Shiv Kumar. Any role of prick smear in pseudothrombocytopenia?
Yes, we can do prick smear in a patient if you're expecting a platelet pseudothrombocythemia and once you've not used the EDT and the citrate are showing clumps. But again, then you will not be giving an automated cell count. You will be giving a manual estimation on the platelet by using multiplication factors which are used in the lab. You will there'll be no clumping seen in such platelet smears. Direct pricks.
Raj Warrior has again come what we have discussed regarding the genetic panels for the pediatric patients. He has told what I meant was the genetic panels and not necessarily a whole genome sequencing, much less expensive and very quick, but not done in any labs in USA.
Okay. So they are not done in USA.
Yeah. He is having any specific genetic panels rather than going for a whole genome sequencing.
Okay. I think we'll have to need to find out the specific panels, but they do have specific panels to know all the syndromic causes of reduced platelets. So there are panels with the NGS panels which are specifically mentioned for reduced platelets, and with the syndromic, the Viscott, Aldrich, and the various syndromes where you have the other physical problems in the patient. You have an absence of radio and this dystrophy and all this. So they do have NGS panels for diagnosing of these.
I think most of the things have been covered. Wonderful talk by you. We would, all the ladies and gentlemen, esteemed guests and distinguished speakers, on behalf of Mumbai Hematology Group, I extend our heartfelt gratitude to each one of you for gracing us with your presence and making today's lecture a resounding success. Our sincere thanks go out to Dr. Vidisha Mahajan for sharing her valuable insights and expertise with us. Your passion and dedication has truly inspired us all. We would all like to express our gratitude to the special guest, Dr. Shilpa Gupta, for our valuable insight, executive committee members, sponsor team, INTAS, Perfect Square team for their coordinations and their generous support in making this event possible. And I would like to big thank to Dr. M.B. Agarwal sir, who has been organizing these webinars since long time, and many people are able to take knowledge of it till the peripheries of the country and across the globe. To our attentive audience, thank you for your active participation and engaging questions. Your enthusiasm has enriched the discussion and made this experience truly memorable. As we conclude today's session, let us carry forward the knowledge gained, continue to strive for excellence in our respective fields. Thank you all. Thank you very much. I'll hand over to the Agarwal sir for further comments.
Just a word of thanks to Vidisha and you for wonderful conduction of the show. Thank you. Bye-bye.
Thank you, sir. Thank you, sir, for the opportunity.